Okay, great. So we, right off the bat, jumping in, we have a couple general slides kind of overall looking at kind of the definition of social determinants of health, and hopefully we can create a foundation that we can kind of work through or work from for the rest of this presentation. But one of the definitions that I really love of social determinants of health was written by the WHO. As you all can imagine, this is a huge, wide-spanning topic and concept. So there's many different ways that people define it, but I like this one in particular. It reads, "The social determinants of health are the conditions in which people are born, grow, live, work, and age, shaped by the distribution of money, power, and resources at global, national, and local levels." So it really doesn't shy away from encompassing everything, which is the way that I do think of social determinants of health, in that they're conditions in every aspect and corner of our lives that that determine our health and well-being for the entirety of our lives. And one thing that I love about this definition is that it acknowledges that it's very much based in the distribution of money, power, and resources. And that is something that we talk about at AMOS a lot, and because we know that so much of the way the distribution of money, power, and resources is within the world is unequal and unfair. And so when we talk about health, we really are thinking about health as a matter of social justice. Okay, great. So this slide gives some concrete examples of social determinants of health. I know that it's a term that a lot of people are really familiar with. There's some that I think that are more commonly talked about than others. Stuff like food access and access to transportation, I feel like are really, you hear about them often when public health 101 courses, that sort of thing. But really a lot of other concrete examples exist. And some that I think we're hearing about more and more, which I think is great, are examples of discrimination and oppression within communities and societies, employment, housing instability, and one that I'm particularly passionate about and that we'll talk about in more detail is early childhood experiences. So you can imagine looking at this list that it's a mess, kind of, because each of these determinants really, you can imagine how it can affect 5 others, or potentially the list of other examples, if it gets tugged in a certain direction towards the positive end, towards the negative end. And this graphic over to the right is also, I love this graphic because it really exemplifies the way that social determinants of health really do have an incredible impact on somebody's health and well-being. This graphic was put together by the County Health Rankings organization, and so they define, in my words, health and well-being as length of life and quality of life. And you can see that clinical care, it's the second blue box down, really only, if we look at the data, clinical care broken into access to care and quality of care really only determines about 20% of somebody's well-being and health throughout the course of their life. And everything else, health behaviors, social and economic factors, and physical environment that are so tied to social determinants of health, make up the remaining 80%.
So now we just want to kind of transition to a slide that's talking about how in emergency settings, that emergency ends up really impacting all of the other social determinants of health. So actually this graphic that you guys can see at the right, the concentric circles, comes from a paper published out of Emory University. So maybe we can link that to you guys later. But basically it's just showing that really conflict, displacement, economic instability, and disease burden all really impact our social determinants that impact other social determinants, as Anna was talking about, which really impact individual and community health. So we have a really, really interesting situation in Nicaragua right now, in that in 2018, as I'm sure a bunch of you are aware of, we had a situation of collective violence in 2018, which really ended up impacting the economy, and then just also social cohesion and how people are interacting together. And you know, we're still seeing a lot of these impacts through today, even though it was in 2018. So this situation that happened in 2018 is really merging with the COVID-19 pandemic and just kind of coalescing together and creating a really, horrible and sad conflict and emergency setting in Nicaragua. So related to the conflict in 2018, the collective violence in 2018, over 60,000 people left Nicaragua, and most of them went to live and work in Costa Rica, the neighboring country of one of the neighboring countries of Nicaragua. But now we actually have reports of a lot of these people returning to the communities, and especially a lot of the communities where AMOS works, because maybe the factories or the agricultural sectors where they were working in Costa Rica are now shut down. And this is all related to that, because of the situation in 2018, the economy really took a nosedive in Nicaragua. And so a lot of people had to leave to find work opportunities in differing neighboring countries. So right now, there is a lot of economic instability in Nicaragua. So over 200,000 people are expected to be unemployed by the end of 2020. And this comes from a recent report that it was really looking at what they think the impacts of both what happened in 2018 and kind of what that's looking like coalescing with what's happening right now in the pandemic situation. So that's a huge number for Nicaragua. It's a really small country, and to have that level of unemployment is really drastic. So also within this report, between 32 to 37%, over a third of people are going to be living below the poverty line, which is less than $1.76 per day. So this is a, just really unfortunate economic situation that goes on to impact health and well-being of all people in Nicaragua. So we do have a quote from one of our community members. We recently went out and were able to visit with community members and dialogue with them about the situation. And one of our community members shared this quote here, which I just want to read to everybody. So, businesses have been affected. We are not selling many pigs or cows. Goods like foods are now more expensive, and there is a shortage of many basic items. So this happened back in 2018, and we're seeing it happen again because the global pandemic situation of COVID-19 is affecting all these economies. And so a lot of people in Nicaragua are seeing this impact what they're doing in their jobs. So for disease burden, Nicaragua has a really high neonatal mortality rate. It's still the #1 cause of premature death in Nicaragua. And so we know that in emergency settings, mothers and children are the people that are impacted the most. Actually, the Lancet, which is a really important journal in public and global health, came out with a report yesterday just talking about the severity of how this pandemic is going to be impacting maternal and child health globally. So it's just a really tough situation. So we know that disease burden could increase for maternal and child health in Nicaragua. And I just wanted to put in this slide just to remind everybody that AMOS is an organization that uses community-based participatory research as a guiding framework for the work that we do. So this is just a very basic example of basically the domains and factors that we take into consideration when we're planning our response in the communities. And so if you guys want to read more about this model and this framework, please go ahead and visit the website that's on this slide. But basically what we want to talk about is that at every step in any intervention or program that we're designing at AMOS, we try to dialogue as much as possible with the community and make sure that we're really working alongside them, with them, and not for them. And so now we're going to have Anna and Ximena talk about 2 case studies from AMOS. One is called Parenting with Love, which is an early childhood development program that we're starting at AMOS, and then our water, sanitation, and hygiene program.
Okay, so I am going to be talking about the creation of the program Parenting with Love. And I think that the basic premise of this program is that it's a prenatal and early childhood development program that's very comprehensive. And so, meaning it addresses many different aspects of how a child develops, how pregnancy develops, and how a child comes into the world and develops within their community. And so it's actually a really great example to talk about social determinants of health because it is very comprehensive. It's very fitting that AMOS started investing in and developing this curriculum at this time, because internationally there has been a renewed interest in investing in and creating childhood development programs. And that is because over the last, more recently, I'd say definitely within the last 10 years, there's been a ton of research day by day that really shows that in terms of experiences and conditions that determine the health and well-being of somebody throughout the course of their life, the ones that really matter the most and are most powerful and impactful do happen in early childhood. And this is for a couple of reasons, but it has to do with, as we can all imagine, your brain develops at a rapid rate during this time. You're also building relationships and learning how you interact and how you are expected to behave within your community. And it's when you learn hope for the future. So that's something that we talk about a lot at AMOS is hope. Moving on, these are just some examples of social determinants of health that are directly addressed within the curriculum of Parenting with Love. And I wanted to take a moment to kind of dive into the definition of social determinants of health one more time, just to exemplify, or just to make an example of the ways that we talk about social determinants of health. It's very common when we talk about social determinants of health to focus on the negative conditions that communities do experience. So a really common thing, if you ask somebody, what is a social determinant of health? What's an example? You might hear food desert, or you might hear lack of access to transportation. And so that's something that is really is a deficit-based framework for thinking about social determinants of health. And one thing that I wanted to focus on is that that's not necessarily, a social determinant of health isn't necessarily positive or negative, it's just a condition. And so something that's happening more and more is that we're shifting the framework, we're shifting our language when we talk about determinants of health to be more of an asset-based language model or framework. And so I've listed here the things that we most frequently hear, and then in parentheses, the alternative in the positive end of the spectrum. So some of these examples that the curriculum addresses are adverse childhood experiences, and the opposite side of that spectrum is building resilience early in life, food insecurity versus access to affordable, nutritious food, discrimination, gossip, and social exclusion versus positive, supportive social networks, and then poor health education versus the alternative that we're striving for is access to healthcare and health knowledge. We can imagine that when we're thinking about working alongside our most vulnerable communities in the United States and also in Nicaragua, that living and existing with a lot of the conditions that you live alongside, being on the negative end of that spectrum, this can lead to toxic stress, reduced options, and high-risk health behaviors, which all directly affect health outcomes. Okay, so this slide explains a little bit about one of the ways that we got information together to create the curriculum for Parenting with Love. We'll talk in the next slide about the other way that we gathered a lot of data, but this one was using existing data frameworks and models that had been developed internationally by mostly the UNICEF and WHO to help inform the curriculum. And so this quote from a paper that came out in 2016 at the top of the slide, 43% of children worldwide are estimated to be at risk for not reaching their developmental potential, is just, that really stuck with me. I think that is an absolutely tragic number to be talking about, almost 50%. And that is kind of an example of what is this renewed interest in childhood development based on these kind of numbers, this kind of data. So back in 2012, The WHO and UNICEF published a paper, published a lot of data. It was called the Care for Childhood Development package. Care for Child Development Package. Yes, I always get those words mixed up. But they basically, what they did is that they gathered together a ton of data, a ton of monitoring and evaluation of programs and interventions, and really took a step back and looked at what are the conditions and interventions and experiences in somebody's life that truly have the highest impact on determining their future health and well-being throughout the course of the lifetime. And what they found was that many of these experiences and conditions are really clustered and most impactful right in the prenatal and early childhood period. So that's what this red circle indicates, is this is kind of their most famous or their most replicated image from this publication. And so that is really what we decided to do, focusing on moving forward with the curriculum of Criança con Amor, or Parenting with Love. Up this circle that you can see up on the right side of the slide is something that came from a publication that, again, WHO and UNICEF put out a couple of years later. It's called the Nurturing Care Framework. And this really had some very useful toolkits for developing early childhood curriculums, development curriculums. And what they did, which I loved and which was so great to be working with material and creating AMOS's curriculum, is that they grouped the most high impact, most powerful conditions and experiences into 5 categories that really are shown to be the most powerful in determining somebody's health and well-being throughout the course of their life. And those are good health, adequate nutrition, responsive caregiving, security and safety, and opportunities for early learning. And these 5 core categories are really what we based a lot of the curriculum on moving forward. All right, the other side of the other way that we got a lot of the data that informed the curriculum of Parenting with Love is, as you all know, because you're all familiar with AMOS, it was community-based, and so it was rolled out by Jessica and Ximena's kind of realm within AMOS, the monitoring and evaluation department. And this was a survey that was very comprehensive and in-depth, and it allowed us to tune the curriculum and really incorporate a lot of the content of the curriculum that directly taken from context-specific data that we had from communities. So AMOS staff and health educators, who are volunteer members of the communities that we work alongside, worked throughout the course of last summer to gather all of this data in Nehapa, and then more recently in one of the rural communities that partners with AMOS in Larax, to get a very comprehensive and a huge amount of information about how children are developing in Nehapa and in Larax, what their developmental scales are, where there might be some room for improvement, health practices, and then what's the environment like? What are the conditions like in these homes where children are growing up and developing, and where pregnancies are taking place? So some of the things that we noted from our data that wouldn't necessarily have been on our radar if we solely based the curriculum on international and global resources were that maternal depression and anxiety were really the rates of depression and anxiety in mothers was very, very high in our communities. So that's something that we definitely wanted to place a strong emphasis on in the curriculum. That harsh punishment was also very common and widely used in the community, so that required more special and focused attention. And then also that exclusive breastfeeding in children less than 6 months of age was pretty rare. So that also, we needed to address these all specifically, and the data that we got from these surveys allowed us to do that in the best, most informed way. Okay, this is a graphic that just quickly explains the model that we're using for the curriculum. That it's called a cascade model, and it's a very particular type of health education model where it's facilitator and coordinator, so 2 AMOS staff, basically coordinate the distribution of these teaching materials and this curriculum to a huge amount of families and mothers within the communities that we partner with. And so basically how it works is that the staff at AMOS, the facilitator and coordinator, throughout the weeks and years that this program will be running, are meeting with groups of volunteer mothers to go over the curriculum, go over each lesson plan so that the material is absolutely clear in the volunteer mothers' heads, and so that they can practice giving this lesson in their communities and have an opportunity and a space to discuss the content and the importance of the content. And then before they take their own physical teaching materials out into their neighborhoods and give that lesson again independently to 10 to 12 of their neighbors and their community members. So you can see that, I mean, if we actually had the amount of little houses that each of those green stick figure moms would be reaching, that's just an incredible span. That's an incredible amount of households and families that this material is going to reach. So that's very exciting. And the other thing about this model is that it's really empowering to teach, and something that came up in the qualitative data that we gathered through the survey that we just talked about is that many mothers in particular wanted access to educational materials. And so the model that we're using is actually is a response to some of the data that we were able to collect from having these discussions with families. Okay, and so this last slide is just basically the layout for the curriculum that we have thus far for Parenting with Love. It's split into 4 modules, and each of them has a specific topic. The first one being the introduction to the program and the model of teaching and building healthy relationships. So we know that responsive caregiving and attachment are really critical early in the lives of children, and how they relate to people and their communities growing up. And so that is addressed in the first section. The second one is a bit more medical. It's focuses on prenatal and postpartum care. So we do know that medical attention is very critical during a pregnancy, and so we did focus more on signs of danger and nutrition during pregnancy, birth plans, that sort of thing. As Jessica mentioned, mortality at this time, in this time period for both mother and baby, are still very, very high in Nicaragua. The third section focuses on breastfeeding and nutrition, from exclusive breastfeeding to supplementing with different nutrients as a child grows up, and also talks a bit about attachment and creating that bond with your child during those early months of breastfeeding. And then the fourth section focuses on early childhood development. So this is really about opportunities of learning, and this is something that I think I always use this example when we talk about early childhood development, because a lot of the points of teaching early childhood development, a lot of them aren't as intuitive as they might seem. You can imagine that if you're a young mother and you have a lot of financial stressors and maybe not as much support in the home as would be ideal, it doesn't intuitively make a lot of sense that with this child that can't speak back to you, say a 4-month-old child, needs to be spoken to and interacted with and played with, when you feel like, they can't talk back to me. So I think that there's information that's absolutely critical in terms of interacting with children, especially for young mothers, that's really can be truly life-changing in this fourth section. The other themes that run throughout the curriculum are healthy relationships and adversity and resilience, and those are woven throughout. Okay. Oh, and I think that I mentioned this. We did just, and Jessica has more information about this, but we did complete the survey in a rural community as well. So not only do we have the input from mothers and families in Nejapa, which is close to Managua, we also have the input of rural families and mothers also now. So moving forward and fine-tuning the curriculum, we're able to take both of those experiences into account. And I think that is it for Parenting with Love. I'm going to be handing it off to Ximena to talk about the WASH program.
Thank you. Okay, so we're going to talk more about the WASH program. So I know that you're aware that in rural communities, we can find several social determinants of health. For example, there are families that may not have access to clean water because they don't have the infrastructure for water treatment or running water in their communities. Also, many families collect their water in wells and rivers, and they usually store the water in open barrels or bucket recipients because they don't have consistent access to running water. So again, this is a problem for them. So in addition, many of the communities use latrines, as you know, for waste facilities, and it's usual to see a lot of animals walking into the house, in the kitchen, near the water sources. So this can lead to water contamination or recontamination of the filtered water. And finally, many people don't learn about the importance of hand washing or rinse fruits and vegetables with clean water. So they are not taught from when they are kids how important this is. So that makes that sometimes when we get to the communities and we get to the families, it makes harder for them to start understanding. So it will be like a completely new learning process they have to start. It's easier with kids, of course, we all know that, but you know that in rural communities, we usually have in the WASH program, with the water filter program, we have more contact with the women or the men from the house, which are basically the ones who are taking care of the filter. So all these factors lead to an increased risk of water contamination and health outcomes like diarrhea and waterborne illnesses. And this can cause malnutrition or, in the worst case scenario, death. So before AMOS began our water filter program, we did a baseline survey in all our communities at that time. This was in 2010. And we calculated that only 4.2% of members of these communities had access to clean water. Like some communities right now have tanks with, and they add chlorine in the tank, but at that time, that wasn't even the case. So if they had some sort of clean water, it was because of manual chlorination. So we aspired the goal to increase access to clean water in our communities. And in 2010, we started our WASH program. So we focused on improving the conditions within households and minimizing the risk of recontamination by helping the families receive a water filter in their homes. As you know, we use the point-use filtration methodology, which is basically having a filter in their house, because we realize there is less chance that the water gets recontaminated. We would love to, but we don't have like the media to install water treatment facilities with piping. I think that's the best option. So we realized the best way we could do to help is using the filters. And as you know, a lot of them are financed and carried out through our short mission terms, or as we call them, delegations, that are coming from churches and universities. So we always start a program in our communities. As Anna explained, we always involve all our members, the members of the community. So we listen their worries, we analyze the context, what they are feeling, what are their thoughts, why they feel they want a filter. And we do surveys in the community and we analyze the practices they have, and we test their water sources to see if the water is contaminated and how contaminated it is, right? So after that, we analyze the data with the community, with the health committee of the community and volunteers, and then we share the information with the community. After that, they are the ones who decide what they want to do. So we always offer the possibility which is best for the community, and if they agree to have water filters, we go to the phase of implementation of the project with our volunteers, or our AMOS staff can do it too. However, we have learned that we can't just focus on getting families water filters. We need to empower the community, so we are currently training our communities in a deeper level through our water promoter programs. These programs is basically training local leaders and volunteers for the community in WASH related topics. So they are going to replicate these lessons that we teach them to their neighbors. It's similar to the model Anna was explaining. So we train them, and then they are replicating the lessons in their community. So they are divided in sectors. Each community is divided in sectors, and there is a water promoter in each sector. So that's the goal. Right now, we have this model in 2 regions, Rax and Chinandega. And our hope is to make this program in all our communities, because we feel like this is the best way to make the program more sustainable. We have learned a lot through the years. We have had really good experiences and really bad ones. And at the end of the day, we think it's really important for the community to feel like they have someone in their community, in their sector. And if they have any problem with their filter, these water promoters are trained to repair the filter and have all the equipment to do it. We are constantly giving them the tools they need, and we're also mentoring them on how to fix the filters. And after these 10 years, we have installed 1,500 filters, and the amount of people that have access to clean water through our AMOS filters has increased to 50.8%. Of course, this number always is moving or varying because we install filters and then there are filters that stop working. But our goal, of course, is to have more than 90%, 100% of people in our communities that have access to clean water. So AMOS has installed 4 different types of filters through the years. We have the Biosan, we have the ceramic candle, we have the microfiber ones, that we call them SAM 3 and SAM 4. The last one we were installing was the SAM 4. You can see is the last picture in the slide. These are really good technology. Each of them have their pros and cons, and we have also learned that different types of water filters which function better in one communities than other. It depends mostly on the climate of the community, and the hardness and the turbidity of the water. After 10 years, as I said before, we have done a lot of work installing the water filters, but there are still families drinking unsafe water, and there are families who have water filters that are nearing the end of their lifespans. For example, we have filters that were installed exactly 10 years ago. Some of them look great and they are working, but the community, it's worried, right? Because they feel like maybe the filters may not be working because it's been 10 years. It's made of plastic, so some of them are about to break. So we were listening to all these concerns from the community, and we realized we couldn't just say, oh yeah, it's still working, don't worry, this is forever, or saying throw it away, it's been 10 years, it's not working, right? So because of that and other things we were analyzing, this year we were planning to begin a study that will involve testing water quality and the contamination levels before and after the filtration of each type of filter in all our communities, so we can determine the effectiveness of each type of filter. And of course, taking into consideration other parameters that we will be analyzing, as I mentioned, the turbidity and the hardness in water. Also, we wanted to expand a little bit more and take arsenic samples, so we can find a link into the anemia results we were having, in some communities. So that we are taking into consideration other parameters that we want to analyze too. So we want to make sure that all filters in general are improving water quality to a level that meets World Health Organization standards. And of course, our plan is to involve our water promoters and different community leaders in this process. And hopefully in the communities where we don't have the water promoters program yet, maybe this can be the start of it. And it will be great because it will be a really complete training for them. Also, one of our goals, and we were exploring the idea to try to standardize our program and our filters in the community. So right now we have 4 different types of filters, 4 different types of surveys, 4 different types of flip charts for the water promoters. So it will be easier for the monitoring evaluation team to analyze all this data and to actually analyze if we are getting the results we want. And of course, this will help us to develop action plans for preventing waterborne illnesses in the communities and make our program more sustainable. So it's a big study we're planning, and hopefully we can start it next year and moving forward with all our plans.